Okay, so now we are going to see about posterior composites. All right, posterior composite is an important short note question. Regarding the material aspect, all that you have already seen. What we are going to see, since it's a clinical posting, we are going to see only the clinical aspects of the posterior composite restoration. So I hope you have all seen the videos that I have shared in the group, and we shall be briefly seeing about some clinical tips regarding posterior composites. After that, I will share the OSCE questions, which you will have to submit the answers again in the group. Okay. So what exactly is posterior composites? Posterior composite restoration is any composite restoration done in the premolars and the molars. Traditionally, as you all know, that amalgam has been the choice of restoration for any posterior caries or any kind of posterior buildup that you want to do. However, there has been tremendous research that has been going on. A lot of technological advancements have come. There's a lot of newer materials and newer technologies that is available, which is now giving a fair chance to posterior composite also to compete with amalgam in cases of posterior teeth. See, our main issue with posterior composite, with amalgam is basically a very strong material. However, it has a major problem of aesthetics. And nowadays, mercury has become a serious concern, especially in the European countries. A lot of the Scandinavian countries, they've actually banned amalgam because of mercury concerns, and slowly that the trend is going to come all over the world. So we need a viable alternative to amalgam. Okay, so we cannot now, since amalgam is being slowly phased out, we need something other than like direct restoration. We've already got inlays and onlays, like indirect cast restorations available, but we don't have a direct restoration. So now, since we are having so much of newer advancements occurring in posterior composites, we can consider posterior composites to be a very good viable restoration for your amalgam replacement. Okay. However, you have to understand that amalgam is a very forgiving restoration, in the sense that even if your cavity preparation, or even if your isolation is not so good, even if your condensation pressure is not so good, even otherwise, amalgam restoration will forgive the mistakes of the dentist and will stay in the mouth for a longer period of time. However, in your composite restoration, that is not possible. Composite restoration requires an exact technique and good finesse from the operator's side, so that they do a good restoration. Only then the restoration will stay in the mouth for a longer period of time. Okay. Now, when they ask you a question of regarding posterior composite, it just does not mean that you do only class 1 and class 2 preparations for your posteriors. Okay, it involves your pit and fissure sealants. It involves something known as a preventive resin restorations, apart from your regular class 1 and class 2 restoration. So if they ask you a question on posterior composites, you have to write a little bit about pit and fissure sealants and PRR also. As you all know, pit and fissures are mostly deep pit and fissures are present in the molars only. So that is where you're going to do. So it's a posterior composite restoration. So that will also come under your answer when you're writing a question answer regarding posterior composites. You have to include pit and fissure sealants and PRR also. Now, what is the protocol for doing a posterior buildup? So first thing you have to do a diagnostic and initial occlusal check. As you all know, composite does not, is not a very good restoration in stress bearing areas. If there is a very deep plunger cusp, or if there is a bruxism or something, if you feel that occlusal pressure is going to be too high, it is better to avoid composites for the timing till even better materials are being introduced. All right. So that is why you need to do an initial diagnostic check for your occlusion also. Then, of course, your isolation pre-wedging. Isolation is very critical in cases of composite restoration. Again, I'm telling you, isolation will make or break your restoration, in the sense that if you don't do a proper isolation, whatever beautiful cavity you have prepared, whatever beautiful restoration you have done, it is going to fail, because lack of moisture control will cause a bonding failure. It will not allow the composite restoration to form a proper bond with the tooth structure. As you all know, composite forms a micromechanical retention. It requires to form a proper resin tags. Now, if there is moisture in between, if it comes, then you will not be able to, the resin will not be able to penetrate into the microporosities. It will not get cured properly. It will not get attached to the composite. So in all levels, it is going to hinder the bonding of the composite restoration. So therefore, isolation is a key or a critical step in your composite restoration. You have to please remember that very well. Next is your pre-wedging. So in cases when you're doing a proximal restoration, if you do a wedging, pre-wedging, that is even before you do a cavity preparation or even before you do a restoration, if you do a wedging, it will cause an immediate separation between the two teeth. So you'll be able to work better, there'll be a better convenience form, you will be able to work with your proximal contours also, you'll be able to do a better job if you do a proper pre-wedging. Next is, of course, a cavity preparation, finishing of the cavity, then proximal reconstruction and then occlusal layering of the restoration, then finishing and polishing, and of course, the final occlusal check. Other things are all is the regular restorations that you do in your amalgam or anywhere. So the key point that you have to take care is you have to do a proper occlusal check, pre-occlusal check before doing your diagnosis time itself, and you have to do a proper isolation, preferably with the rubber dam. I've shown you certain videos in which you will see that the isolation was all done with the rubber dam, not just with a cotton roll or the suction tip. So rubber dam will give you a more complete, more thorough isolation when compared to your just your cotton roll or your suction tip. Okay. Now, so we will quickly briefly see through all these steps now. First is the diagnosis. Of course, diagnosis you have to do, that goes without saying. Whatever restoration you have to do a proper diagnosis. And then occlusion must be checked. You can use your articulating paper to see where all is the stress bearing areas, and you will try to try to make the cavity as small or as moderate as possible, not go for very extensive cavities. For very extensive cavities, it's better to go for a cast restoration, because that will help you to bear the stresses more better than compared to your composite, which has got a lesser wear resistance in the high stress bearing areas. Okay, and try to keep the margins wherever there is an occlusal. You can see this spot of the articulating paper on the occlusal surface. Better to keep the margins away. Either the occlusal load bearing area should be either on the composite or it should be on the tooth structure, not on the margin, on the cavo surface margin. You try to avoid placing the cavo surface margin on the occlusal contact area to minimize the wear. Okay, then of course you can see the picture here. They have kept a rubber dam, the lower second picture down over here. They have kept a rubber dam, did a proper isolation, and they have placed wedges also. Even before they have doing the cavity preparation, they have placed the wedges here. This is to give a proper separation between the tooths, because you will be able to open the contacts well, and you'll be able to place the margins in the proximal side. Also, it will help you in allowing a proper mattressing and establishing good contact. Rubber dam, I've been telling you repeatedly, rubber dam is the best way to isolate the tooth from any kind of saliva, even blood, or any tissue fluids, moisture, any fluids that is coming will be effectively sealed or effectively removed from the working area by the rubber dam. Now, next is your cavity preparation. So cavity preparations, as you all know, basically, I'll quickly go through that. I have not put all this in the slide. Cavity preparation, there are 3 designs for your composite cavity preparation. That is basically your conventional, bevel conventional modified. You can also have your tunnel and slot cavity preparations. I'm sure you've all studied regarding this quite often. Conventional is basically, conventional preparation we don't do so much. Conventional is basically amalgam, like your amalgam preparation with a proper box with a uniform pulpal floor, axial wall, gingival seat perpendicular to long axis of the tooth. This kind of restoration is done only in the root surface if there is subgingival caries. Bevel conventional is also not being done. Bevel conventional is usually done if you're replacing a existing conventional restoration, remove it and just place bevels. The most commonly followed cavity design for composites is your modified preparation. Okay, so modified preparation is basically you are just following the outline along the caries margins. Okay, so wherever the caries is, you are just removing the caries. You do not have a fixed outline form. You don't have a fixed depth. Even the depth of the cavity will be decided by the depth of the caries present only. There is no fixed like 1.5 millimeter or 2 millimeter like that. We don't have a fixed depth of the cavity preparation or the outline form. In class 2 preparation also, it is not necessary that you need to open the proximal contacts on both the sides. Where if there is caries in the mesial side, along the on the buccal side, just open the buccal contact alone. No need to remove the lingual contact or open the lingual contact. Okay. Similarly, you have to include all the caries, pit and fissure. You do not have to do extension for prevention like your amalgam. What is extension for prevention? Even if there is no caries, we used to involve all the pit and fissures, even if it is caries free, just because you haven't to follow a specific design. For example, in a premolar, you have a butterfly shaped design. So whether the caries is there only on the mesial pit or only on the distal pit, when you are doing a conventional cavity preparation for amalgam, you are supposed to involve both the mesial and distal pits and go for a butterfly shaped design. Like that, you don't have to follow any predetermined cavity designs for posteriors, in the sense that only if there is caries, you need to extend the outline form till that caries level only. So for each patient, it is going to be different, right? So if a patient has got caries only in the mesial surface, then you have to make a modified scooped out preparation only on the mesial surface. The next tooth will have caries only on the center or the distal portion. So you have to just remove that. So there is no fixed outline form for your posterior composites. Similarly, pulpal depth and the axial depth also need not be uniform. So if the caries is deeper in the mesial aspect, you go deeper. And if it is shallower in the distal aspect, you can go shallow. You do not have to make a uniform flat pulpal floor like your amalgam preparations. And depth also depends only upon the caries, not on anything else. You can have minimal axial depth, that is just below the proximal DJ, just 0.2 mm below the DJ. And what are the different burrs that you can use? You can use a 330 or a 245 pear-shaped burr, or you can even use a diamond point or even a round abrasive diamond burrs. Okay. Now, cavo surface margin see again, cavo surface margin, you make just understand one point, that in occlusal surface of your posterior composites, you need not put a bevel. When you're doing an anterior case, we tell you to make a bevel so that the margin of the tooth and the composite will be blended. You will not have you will not be able to see a visible interface line between that. You will have more area for your bonding. You will have a better retention. That's why we ask you to give a bevel in the anteriors. The main thing you have to understand in your posteriors is that you don't have to make any occlusal cavo surface bevels. Why? Because when you have an occlusal cavo surface bevel, only a thin layer of composite you can place, because bevel will be only, you will be removing only 0.5 or 1 mm of tooth structure. So that thickness is very, very less. So that bevel, if you place, and if you place a composite on top and there is occlusal masticatory forces, immediately that beveled area is going to chip off. It will result either in the wear or in the fracture of the composite. And it is very difficult to finish an occlusal bevel also. So that is not required. All right. So that is a key point that you have to understand. In posterior composites, you do not have to make an occlusal cavo surface bevel. All right. All you need to do is roughen the caries, roughen the cavity. You don't have to make a very smooth, because as you know, it is a micromechanical retention. We don't want smooth walls. So you basically, a rough wall is necessary, and your primary retention is because of your etching, priming and bonding. So you don't have to make any grooves. You don't have to do for any coves or any secondary retention forms is not needed much. Next is you can have a gingival bevel. Gingival bevel, there are certain rules that you have to understand where and when you can place the gingival bevel. When the gingival seat is close to the cemento-enamel junction, there is no need to place a bevel. Okay. If it is supragingival, well above the CEJ, it is very much not above the gingival level and not near the cementum at all, a gingival cavo surface bevel can be placed. Okay, it can be placed on the facial and the lingual walls of the proximal box, in which they are very, very wide. Okay, wide facial lingual boxes, it can be placed at a 45-degree angle. This can be done using a tapered fissure or a diamond tapered fissure burrs. Okay, occlusal bevel not required. Gingival bevel only if it is supragingival and in cases where there is wide facial-lingual proximal boxes are there, in which you have to place a very conservative small bevel is sufficient, not much. All right. And then, of course, your regular pulp protection. After the cavity preparation is done, you have to do a proper pulp protection. Either you do place, if there is a deep cavity, you can place a calcium hydroxide. If there's a little shallower cavity, you can place a GIC. You can go for a sandwich restoration also. Or a dentin bonding agent is sufficient if it is a very, very shallow cavity. Now, coming to the matrix placement for class 2 cavities. So you can either have a clear polymer matrix. All right, these matrices are very, very flexible, but they have the advantage of being light transmitters. So the light which is needed for you to cure the or polymerize the composite resin can easily pass through these matrices. This is mostly commonly used in the anterior regions, not in the posterior regions, because these are very flexible and will not allow you to get a proper proximal contact. So you can use your Toffel-Mayer matrices, which are ultra thin. You can use sectional matrices. These are the last two. This one, Palodent, and your composite matrix are basically sectional matrices, which will have a ring like structure into which you place the mattress, and then use forceps like your rubber dam clamp forces are there, similar to that, and then place it in between the two to be working on. So if you can see this picture, they have placed the matrix with the help of this ring, which is stabilizing the matrix in the place, and there's a wedge in between also. Okay, so you have to have a proper separation so that you can place a matrix, and proper wedging is necessary to get a good contact. Next, you'll come to quickly see the pit and fissure sealants also. So pit and fissure sealants are basically, wherever there are deep pits and fissures in young patients, preferably in people who are not able to brush very well. This is usually seen in children, in which there is not proper calcification of the fissures have not occurred, and they are very deep. Even the toothbrush bristles will not actually penetrate to the depth of the fissure, but food can easily go in and start caries. So such susceptible sites for food stagnations has to be diagnosed early, and you have to place these pit and fissure sealants. These are basically preventive restoration. These are a type of preventive strategies that you're doing so that caries does not occur in your permanent teeth. So what you do, basically you place a self-cured composite, and you can have some tinted, you can have pink color tints. You must have seen in your perio department they are using it, so that you know that you have already done a pit and fissure sealant. If you place a clear composite resin or white color, you may sometimes will not be able to differentiate between the tooth and the composite resin or the sealant. So it is better to place tinted ones so that you know that they have placed the pit and fissure sealant in those teeth. So pit and fissure sealants, again, you have to do the same thing. You have to do the acid etching for 20 seconds, place the bonding agent and the pit and fissure sealant, and then cure it. All right. And of course, you have to see the occlusion also. You don't make sure that you don't create any high points over there. Next, there's something known as preventive resin restoration. What is preventive resin restoration? Is basically you have minimal caries. See, pit and fissure sealants is indicated in places where there is no caries, whereas PRR or preventive resin restorations are indicated in places where there is mild caries, minimal caries in one or two pits, and the other pits are all free from any sort of caries activity. So what you do, you just do a very shallow cavity preparation using special burrs. You have a pear-shaped diamond point, or you have a fissurotomy burrs. You have got special fissurotomy burrs are available, with which you just do a cavity preparation. That is basically just remove the caries alone. There's no need to do any proper cavity. Just remove the caries alone, and the fissure may be widened slightly. The uninvolved fissures can be slightly widened so that it doesn't become a food trap. Following this, you isolate the tooth, you etch the tooth, and you usually how you do your etching, bonding, and your resin restoration. You either use a hybrid or a packable resin restorations, and you fill up the caries pit alone, and the other areas you have a pit and fissure sealant kind of a restoration. So this basically will serve a dual purpose. What is preventive resin restoration basically does is initial caries alone is removed, and at the same time the uninvolved fissures are also being sealed up so that they don't get have any caries in the future. So in high risk individuals, like people who are having a high caries risk, you are doing a conventional minimal intervention technique here just to remove the caries alone and seal the other surrounding pits and fissure areas. So you can see this burr here. If you do a cavity preparation with a regular straight fissure burr or a pear-shaped burr, this is the amount of cavity that you're going to do. But you've got these special fissurotomy burrs that are very thin. So you just basically you're just trying to widen the fissure slightly, and so that you allow the sealant to flow inside. All right. So you got different types of burrs that are available, and this is how it will look. So before, you can see some slight caries lesion is being starting here. So they just did a cavity preparation, restored here, and sealed the uninvolved fissures also. So this is how it will look like, which is basically a preventive as well as a very minimal intervention strategy to arrest the caries that is present, as well as to prevent further caries in the uninvolved fissures. So now coming to the restoration portion of it. So how will you do restoration? You all know that you have to do a layering technique only. You cannot do bulk restorations because polymerization is done only in 2 millimeter polymerization occurs only in 2 millimeter increments because the light will not penetrate in deeper increments. So basically you're supposed to do a 2 millimeter increment all over the place. So how you do these increments? You usually use this oblique layering technique. That means one over here, then again third increment again on this side, then fourth obliquely here, fifth layer like this. So you do an oblique layering technique. So this, there are again couple of variations in this. You have either a successive cusp buildup, you have a separate dentine and enamel buildup, or you have separate dentine and enamel buildup using a putty index. It's something like a stamp technique. We'll see all the three techniques quickly. So first is successive cusp buildup. So what is being happening here? You can see this picture. So you have your, this is a lower first molar. So you got your lingual cusp here and your buccal cusp over here. So what they are doing in this picture B, you can see, they are just building up this mesiolingual cusp first. Then they are going to the distolingual cusp. Then they are going to the distobuccal cusp. Similarly, each cusp is being successively built. So they are doing, so they are doing successively. So each cusp, first you will take one cusp and then build it up completely till the occlusal surface. Then go to the next cusp. So again, layer by layer, you build up the next cusp. Similarly, you do, so each increment is being done. So you have your central cusp, they are doing buccal central cusp, and then they're doing the, finally the mesiobuccal cusp. So like this, they are successively building each cusp so that it is having a good restoration, layering restoration. The next technique is to have a separate dentine and enamel buildup. That means first you are doing the dentine portion of the restoration. So the deeper portion is completely packed first, and then you go to the superficial enamel level. So you'll use a different type of resin for the dentine, more yellowish, more opaque one, and you can use an enamel composite which is a little bit more translucent, little bit more whiter. The shades will be differing for your enamel and your dentine composites also. So here first they do the dentine buildup, then they go ahead with the enamel buildup. Next, the third technique is to do a separate dentine and enamel buildup using an index. So before you start, this is a very easy technique in building the morphology, in which you need not sit and build up the pits and fissures afterwards. You know, it is very difficult to sculpt the anatomy in a plastic stage of a composite restoration. Unlike your amalgam, which you can do a proper carving, in composite it is little difficult because it will stick to your restoration, stick to your instrument. It will be little difficult to sculpt it. So what you do, you have an easy way of doing it. So you can, before starting the restoration itself, you take an impression of the tooth. This technique can be done in non-cavitated lesions only. If there is a cavitated lesion, you cannot do this cusp buildup with an index or a stamp technique because you don't want to recreate the same cavity in the restored tooth. All right. So only if it's an uncavitated tooth like this, it is caries, but the occlusal morphology is fine. All right. Such teeth, you take an index. Either you take with a putty, you make it, or you can take a clear resin, and with the help of your either you can take your applicator tip or something. You just flow the resin there and then cure it. So you will get the occlusal morphology as a ready-made stamp. Similarly here, if you take an impression and you wait for it to set and you take it out, you will get the impression of this tooth which is reproduced in the putty impression. So then you proceed with your regular cavity preparation, your pulp protection and all that, and then you start placing the composite layer by layer. When you come on the topmost layer of the composite, you can place it and press it with, and press this either the stamp that you have made or the putty index that you have taken, so that the anatomy on the stamp or the putty will get transferred to the plastic composite resin. Once that happens, then you can cure it so that you don't have to separately do a anatomical creation on the occlusal surface. So similarly here, what they did here also, you can place the composite restoration layer by layer. Once you come to the top layer, since it is clear stamp that you have done, you can even light cure it through the stamp here itself. But in this case, you cannot do it. You have to press it, remove the putty, and then cure it so that you get an accurate reproduction. So you can see this was the pre-operative picture here, and you can see the same occlusal anatomy being reproduced in the posterior. So your work is lessened. You don't have to do too much of finishing and polishing. You don't have to do an occlusal check. You don't have to do occlusal corrections, because that will automatically has recreated what was there pre-operatively. So your work becomes easier. You have basically saving time. So what all we saw in this oblique layering technique, we saw a separate cusp buildup, we saw enamel and dentine buildup, and then we saw the stamp technique or the putty index technique, something similar which can be followed. Next, coming to the after your restoration is done, finishing and polishing is very, very critical in composite restoration, basically all restorations. Unlike your amalgam restorations, this finishing and polishing can be done in the same sitting itself. You have to wait for some time, 15 to 20 minutes, so that the polymerization gets completed, and then you can start. So once the polymerization is complete, there is something known as an air inhibited layer on the top. The oxygen in the atmosphere will inhibit the polymerization occurring on the topmost layer of the composite. So that will be slightly sticky, unpolymerized layer. That will be the top layer that will be present. So that layer has to be removed. That is known as an air inhibited layer that has to be removed. So there there are different systems that you can use for finishing and polishing. You've got your you have your burrs which you use, those yellow ring burrs that you have in your kit. Then apart from that, you've got your rubber discs, rubber cups, you've got your flexible discs, you've got your these kind of rubber points are available which have abrasives coated on top of them. This can be used in your micromotor handpiece. This cannot be used in your aerota. These can be used in your micromotor handpiece, like this picture over here, and they can either have a polishing paste separately, or it can this itself will have some kind of an abrasing material stuck on top of the rubber point, but it is always better to do a wet polishing. Why you don't want to do dry polishing is because dry polishing can generate a lot of heat, all right, and that will cause pulpal irritation. Not only that, it can even disturb the restoration also. So you have different polishing pastes that are available, which can be either plain pumice, or you have you've got your commercially available polishing paste that contains silica, alumina, all these things are available, which can be placed on top of the restoration, and a good polish can be obtained. Just because it is a posterior composite does not mean you don't have to polish it. Polishing is necessary not only for aesthetics, even for a good finish. You don't want any further plaque accumulation on top of the rough restoration and causing secondary caries, and all sorts of trouble will generate. So you need a smooth and polished restoration, whether it is composite or amalgam, whatever may it be. Also, you saw the videos that I sent you. So they are using some dyes or tints. All right. So even to recreate the caries, fissure, or pit also can be done. If you have a good artist, you can use brushes or thin probes just to place the tints, just to recreate the anatomy of the stain, pit, and fissure. That also can be done. So you use a water coolant, use a light pressure and slow speed in a micromotor handpiece, and you finish the polishing and restoration. And you at least wait for around 15 minutes or so that you are able to completely finish the finishing and polishing. So quickly we'll see the advantage. We're running out of time, so we'll just see the advantages. You know, the advantages is that, of course, aesthetics, you cannot match the aesthetics of composite with any other restoration. Then you can conserve the tooth structure. Like I told you, there is no fixed depth, or there is no extension of prevention. It's a minimal intervention technique, so you conserve as much of tooth structure as possible. So you get a very strong tooth which is remaining after the cavity preparation. All right. So addition to the tooth structure is, as you know, it's mechanical, so it gives you good adhesion, good marginal seat. Insulated, because it's a non-metallic restoration, it will not conduct so much of heat. All right, unlike your metallic restoration, like a cast restoration or amalgam, which can conduct. So your pulp will have good thermal insulation, low thermal conductivity, no galvanism. As you all know, it is a non-metallic restoration, so no galvanism. Similarly, it is a radio opaque restoration. So there are certain disadvantages. Anything that has advantages will have certain disadvantages. Main problem with polymerization shrinkage. So polymerization shrinkage, we have different strategies to combat polymerization shrinkage. That's a separate topic altogether. But even this oblique layering that you do is something to reduce the polymerization shrinkage, but it cannot be eliminated completely. It can be only reduced. All right. So since polymerization shrinkage is there can be some micro leakage and secondary caries, or post-operative sensitivity can be a problem because of this shrinkage issue. Then you have got your reduced wear resistance. Like I told you, it's not as wear resistant as your cast metal or amalgam, but it is getting there. We are having certain, specified filler materials are being added, certain additives are being put in the composite, and research is still happening to make a more stronger and a wear resistant composite. And it has got a high coefficient of thermal expansion, and last and most important thing, it is very, very technique sensitive. Like I told you, you have to do a proper isolation, and you have to follow all the instructions to get a good restoration. Indication is in small incipient class 1 cavities. So like pit and fissure, like I showed you, like preventive resin restorations you can do. You can do moderate class 1 and class 2 restorations. You can do sealants in deep fit and fissures. And aesthetics is very important. You have to do, of course, composite restorations, and wherein good isolation is possible. You can also be use as a foundation or a core material under full crown restoration, especially in your all ceramic restorations. It is preferable to do a composite core rather than your amalgam or any metallic cores. And of course, in patients with good hygiene and low caries rate, it is indicated. So similarly, what are the contraindications? Obviously, in patients is having high caries activity or poor oral hygiene, it is contraindicated. And most important thing is where there is isolation is not possible, you have to definitely avoid composite because it will fail. And if there is multiple large restorations have to be placed, it is better to go for your metallic restorations. And patients having grinding habits or bruxism, again, it is not as wear resistant. So again, it is not possible to give composites. And similarly, if it is subgingival, it is better to avoid such kind of restoration, post-composite restoration, and go for something which is more forgiving in nature for your subgingival restorations. I think we are running short of time. So with this, we'll stop the talk here. So if there are any doubts, please put it in the group. All right, we will try to answer them in the WhatsApp group. I will be putting some OSCE questions also, for which I need the answers before 3 p.m. Is that all right? Okay. So shall we end the meeting? Any doubts? If you want to ask, there's just 3 minutes remaining. Any doubts quickly? No? Okay. So shall we end the meeting? Okay. Thank you. Thank you all.
Thank you.
Thank you, ma'am.
Thank you, ma'am.